Sometimes healthcare initiatives fail not because the idea was bad, but because the operational reality underneath that idea was never really solved. Today, I want to talk about a campaign we launched across 1,700 hospitals that people genuinely loved, and what it taught us about the difference between a compelling idea and a working system. I'm Bruce Spurlock, a physician and healthcare leader committed to helping professionals and decision makers navigate change with clarity. On viral healthcare, we look at the ideas spreading across healthcare and what it takes to implement them wisely and sustainably. So today is kind of a mea culpa. Today is one where I talk about how I got a big smile on my face because we were going viral with something. It was fun to watch that happen. And then the reality set in a little later. And that's the part we're going to learn from today. So let me start with setting the stage. What was the problem we were dealing with? It was 2016. We were working with American Hospital Association and 30 some states and over 1,700 hospitals on a big national campaign and program to improve quality that was funded by the Centers for Medicare and Medicaid Services, CMS. And there were other organizations doing this with across the country. It was really exciting. We were making really good progress, but we were starting to hear this rumbling from the front lines because we talked with both senior leaders and the front lines. And so we had a really good understanding what was happening. And they kept talking about that there were these endless quality initiatives. We'd make progress, but we'd never stop working on them. There was always a new checklist. Like every couple of months, there was a new checklist they had to do. There were risk assessments. Every patient needed dozens of risk assessments for each of the individual improvement and patient safety priorities. There was fragmented messaging about what was important. There were competing priorities. There were a lot of priorities. Everything was a priority. And at that time, EHRs were unevenly adopted. So mostly across the country, this was going on a manual basis. There were these paper forms and things that people had to fill out. There were even websites that described how to create a protocol or a good protocol form or a risk assessment form to use in the setting. So it was really a time when it was sort of additive. And so every new initiative claimed to improve patient care. In fact, there might have even been good randomized controlled studies to show evidence that it made a difference. But the frontline staff experienced it very differently. They experienced it as a cumulative operational burden, more paperwork, more expectations, and worst of all, it took them away from spending time with the patient. I mean, that's the core thing that nurses love to do, is to be there and connect with their patients. So we heard this rallying cry from a number of people. Is there a way that we could reduce the number of things we do and still accomplish the same outcomes? Could we focus, and could we sort of multitask without necessarily having to increase the amount of work we did? So our team got together, and working with American Hospital Association staff, we created the UP campaign. It was really fun. It was really exciting. It had three components to it: wake up, get up, and soap up. Three components to the UP campaign. Let me kind of briefly describe what each of them was. Wake up was trying to deal with this reality that was facing in hospitals, that patients were being over-sedated. And it was like this question: would you rather have an agitated patient or a quiet patient? And over time, people started getting too much sedation because the quiet part was really the preferred part while they were in the hospital. And they could wake up to do certain things, but quiet patients were desired patients. Get up was about developing mobility and strength. And there was a movement to even get intensive care unit patients on ventilators up. So that was exciting at the time to think about increasing the mobility and strength. In fact, a lot of patients were being held in the bed and encouraged not to get up because of this work we did on falls reduction. And the problem was we kind of overshot. Let's put patients in bed, and they get pressure injuries and all sorts of things happening when they do that, including weakness. And the third part was pretty obvious. It was soap up. So that's about hand hygiene and reducing infections and the impact of hand hygiene. And lots of studies had shown that people get better for a while at a lot of institutions, and then they decline. So how could we tackle all three of those things together? The goal was to try to simplify That was it. Let's do less and accomplish more, not adding another disconnected initiative, another quality initiative that people were talking about at the time. And it resonated so quickly. You would not believe the number of people that jumped on. It was kind of fun. So the messaging was intentionally simple. It actually took us a couple of months to boil down what we were going to do into those three different topics. And so they were easy to remember. Everybody, non-clinicians, administrators, a whole bunch of people were talking about the UP campaign and the three components. It was super easy to communicate. It was one of those sticky kinds of things that we talk about in healthcare, a real sticky message. It was clearly patient-centered, and we had PFACs and the patient-centered advisory groups that were all supportive of it because they thought this was how to empower and engage patients as part of the caregiving team in the component. And it was really clinically intuitive. I mean, we had literature and evidence to suggest that ambulation tackles several different activities. Over sedation causes problems, and getting appropriate sedation was helpful. So it was not hard to convince even the clinicians it was the right thing to do. We even boiled it down to trying to get it to one simple statement, like, is my patient awake enough to get up today? And if the answer is no, they're not awake enough, we got to deal with that. And if they were, then we had to do the second part. We have to get them up. And of course, ambulation and walking is different depending on the different capabilities. So sometimes that meant sitting up at the edge of the bed or sitting in a chair or making a few steps. But sometimes it meant, dramatically increasing the ambulatory component of what people were doing. And the impact was profound. I mean, if you think about it, people don't get pressure injuries when they're not laying in bed. Muscle wasting, especially in the elderly, like 7% of their muscle strength declines every day that they're lying in bed without moving. And what happens? They end up going to a nursing home more often when they're like that, which is a higher risk for being readmitted. So it dealt with readmissions. Delirium, there was a lot of research about delirium and how ambulation and just getting people up is good. And also, obviously, decreasing sedation as a stimulus or a cause of delirium. Infection reduction would go down. And interestingly, patients and their families were kind of excited. They actually saw that this was actually what was happening. So it had this general resonance all across the country. Nurses and administrators loved it conceptually. I mean, I can't tell you how many people said, this is great. This gets us back to what we used to do. I mean, these are some of the more senior nurses who thought their lives are all going to be about checklists and risk assessments and not about talking with patients, encouraging them to getting up. And that was this visible progress that you could actually see what that was happening. So patients were sitting up. Patients were walking earlier. There was less sedation, more visible recovery. These are the kind of dominant themes of the UP campaign. There was research that ambulation helped with delirium and agitation. So you kind of tackled both of those. And it was bigger picture thinking rather than this sort of endless period of tasks. So people just loved it. They connected with the philosophy behind the campaign, not just the interventions. I mean, it was kind of one of those really attractive things to do. And, even the understanding that this wasn't going to go on forever. We called it a campaign to try to tell people that we're just not going to do endless work like we did before. So it had all these components to it. And boy, did it gain momentum. I mean, it was fun. I saw thing take off across the country. It was amazing. I mean, we had national meetings. We had 300 and 400 people attending national meetings a couple of times a month just to learn about the UP campaign and how to implement it. My team did multiple webinars in individual states with individual organizations. We went on site. We did statewide presentations on site. We went to early adopter hospitals. We even got mentioned in the New England Journal of Medicine as a geriatric way to think about reducing delirium. And so it was really exciting. The momentum, the uptake, the interest. This was all people were talking about at the time. And it felt like we had done something really useful. We'd kind of broken through what traditionally was just additive work. All of it good, all of it usually evidence-based and scientifically founded. And now with something that we were just seeing this resonance and this uptake. So while we were on the road talking about about this, both virtually and in person, it was a hit. No question about it. And then during implementation, some questions started arising. They started small at first, but that's when implementation changed how I viewed what we were doing with the up campaign. So, a real important question, real important reality based question. Who owns patient mobility? And of course, we had an answer to this, and the answer was it's different at every hospital. I mean, at some hospital, it was the transport team, some hospitals, physical therapy, other places, physical therapy was about assessment and writing a prescription rather than actually doing the therapy because of the staffing. Sometimes it was the nurses, or sometimes it was the nurses guided with family members who were there. But the fact that we really couldn't get this patient mobility ownership nailed and made it nailed easily was a problem. The second part was, okay, you're going to have me do these things, which is great. I like doing them. I think it makes sense. What are you going to take away? What things, what assessments, what checklists, what paperwork do I get to give up in order to do that? And how do we operationalize this consistently with every patient? What about the patients who are super ambulatory, the patients that are young versus the patients that have multiple medical problems, maybe came in with some cognitive difficulties to begin with? How do we sort of consistently do that when patients aren't really widgets? It's nice to talk about all these things when we think about the sort of model or median patient, but it's different when you start talking about the variation. And more importantly, how do you measure success? This was a key question, this metrics thing. So the campaign moved from conceptual simplicity to operational complexity, and my eyes got really big then. So the hidden problem was it was additive work. I mean, it just became something else that the nurses had to do. Nothing was removed. Every checklist, they still had to keep doing it. And remember, these are mostly manual. I mean, it'd have been one thing if you could have automated it and made the checklist sort of easy to do with an EHR, but at the time that didn't happen. All of the assessments remained, and sometimes assessments were daily or twice daily to be able to do that. And the existing reporting, the systems we had to report and collect data was that remain. So instead of simplifying the care that we wanted to do, it just brought another layer onto the nursing staff. So here's something important to think about. Healthcare organizations often add initiatives without redesigning the workflows underneath them. Big aha for me, big aha for our team. And that just was compounded by something that we normally do in the work that I do in quality and operational improvement. We normally go hard on having easy, objective measures that demonstrate we're making improvement. But that didn't happen with the up campaign. Hospitals didn't want any more metrics. They told us, like, we'll want to implement these things, but we don't want to measure it. And so when you don't measure it, you don't really know if you're implementing well. It's kind of the fundamental thing about, trying to think about implementation, is trying to figure out how to do a measurement infrastructure, a measurement management system that is both effective and easy to implement. There was no clear outcome tracking. We didn't actually know if people weren't going to nursing homes, even though the literature suggested that. We didn't really have ways to capture that. I think if we'd have done it now, we might have been able to bootstrap those onto the EHRs, or at least query the EHRs in ways that are a little bit more meaningful, and we might have been able to do some of that. And we didn't have ways to define it success operationally. I mean, there were these measures out about ambulation, but they were kind of soft and fuzzy, and they're still a little bit soft and fuzzy. There was some measurement about how sedated somebody was. So they were out there. They just were not easy to capture, not easy to report on, not easier to feed back into the systems. So this is a classic one for things that go viral and aren't sustainable. You can measure exposure or what you're doing, but you can't measure transformation. You can't say, did we really make a difference in the system? So we had a lot of evidence that the number of presentations that we gave, the number of hospitals we reached, the amount of positive feedback we got was really high, but we didn't really know, were patients improving? Were mobility rates changing? Were outcomes getting better? Nobody really knew. We had guesses, but we really didn't know. And sometimes when you guess, you have the biases that you bring. And we really wanted this to work. We had a lot of biases about making this an effective program. And so our idea was, let's listen to all the people that are singing our praises without really asking deeply if they're being implemented broadly across all these hospitals. So the deeper lesson is healthcare is full of really, really good ideas. The real challenge is often operational redesign. So whose ownership? Who's going to staff it? What's the workflow going to be? Where's the accountability? Where are the incentives? How do we sort of tackle efficiently and effectively this idea of measurement? So conceptual simplicity doesn't necessarily eliminate operational complexity. In fact, it might actually create more of that if you don't really think it all the way through. So here's the bigger pattern of all of this. Healthcare organizations often mistake enthusiasm for readiness. Now, let me say that again. We often mistake enthusiasm for readiness. Just because people like an initiative doesn't mean they can implement or sustain it. So improvement work often becomes additive instead of transformative. And that's part of the reason we're doing these podcasts. Part of the reason I'm interested in this is to take the lessons that I had personally and help people not make those same mistakes, or at least make them less often. We had this realization at the very end, looking back 10 years later, that it was all sizzle and no steak. We had this incredible, great marketing campaign that we'd spent several months. We had vehicles and we had a distribution method through the American Hospital Association and with all the technology we were using, but we didn't have a clear aim. We didn't do complete implementation. We didn't have operational ownership, and we didn't have a durable measurement management system. So at the end, it became all sizzle and no steak. I mean, if I think about it now, it's one of those things that actually motivates me strongly. I had a huge smile. I can't tell you how many times the team and I talked about how fun it was. We were re-energized to do healthcare when we came up with this, primarily because it made sense and primarily because it resonated so well. And then I have to tell you, it was disappointing. It was disappointing that it didn't have the duration and sustainability that we thought, and the impact that we thought it was. So before you add another quality initiative, another framework or workflow or new platform, ask yourself, what operational burden are we removing in exchange? Because improvement work that only adds responsibility rarely stays sustainable for very long. It's often replaced by other activities that have the same great idea, but not necessarily the redesigned workflow that underlies all of this. So I want to thank you for listening to Viral Healthcare. If this conversation was useful, share it with a colleague who's navigating change. And if you like more thoughtful conversations about the ideas shaping healthcare, be sure to follow the show. I'm Bruce Spurlock, and I'll see you next time.